In their ongoing efforts to reduce payments for services rendered, third-party payers have begun reducing reimbursement when certain ICD-10 diagnoses codes are part of the final coded record. They are terming these codes low acuity non-emergent, abbreviated LANE or LANE. Some of these third-party payers are automatically reducing payments when LANE diagnoses codes are submitted on a claim. As you know, patients come to the emergency department for a multitude of reasons. Sometimes they come with issues that, after extensive diagnostic, end up not being urgent, but we don't know that from the beginning. As providers, we still provide them with the needed care and treatment, whether they present with a heart attack or a hangnail. The service needed is provided regardless. It is interesting that EMTALA requires us to see the patient and perform a medical screening examination on all patients presenting for care, and yet third-party payers are deciding after the fact to what degree they will cover payment for the encounter and the care provided. The truth is, it's just as illegal for these payers to withhold or reduce payment based on the final diagnosis code as it would be for us to turn a patient away and refuse to provide them with an assessment and stabilization or treatment. It should be noted that Concord has a dedicated team of colleagues, revenue cycle management, and coding partners who are tirelessly advocating on our behalf to combat this bad payer activity. Payment for services should be based on the patient's presenting complaint and our documentation of the encounter. Our documentation matters. It must be specific and complete. This includes the final diagnosis. Many of these so-called LANE codes or low acuity non-emergent codes are codes for symptoms only or for unspecified diagnoses. Our best documentation practice includes information that leads to the most specific ICD-10 code possible. There are things that we as providers can do to help in this fight. Whenever possible, avoid using symptoms as a final diagnosis. Symptoms as diagnoses are sometimes unavoidable, but whenever possible, the final diagnosis should reflect the cause of the patient's symptoms. As an example, a patient presents with a cough that they've had for 2 days. They get this cough every December when the cedars pollinate. Chest x-ray is normal. The patient has clear rhinorrhea and boggy nasal turbinates on exam. The final diagnosis should not read acute cough, but rather acute allergic rhinitis due to seasonal allergies. Again, the cause of the cough. We want to avoid the use of the terms possible or probable as part of the final diagnosis. As an example, in the case of a 2-year-old with a fall that led to an injured elbow, x-rays showing no acute fracture, but you splint the child knowing an occult fracture is a possibility. The final diagnosis should not be possible fracture, but rather a more definitive diagnosis of contusion or sprain, and then include in your medical decision-making statement the possibility of occult fracture as the need for the splint. It should be noted that when a patient presents with an injury, that the mechanism of injury and time of its occurrence is documented. Contusion or sprain of the elbow due to a ground level fall. A few more helpful hints when it comes to documentation. Avoid using the terms unknown or unspecified as the part of the final diagnosis. In the same example of the 2-year-old who fell, instead of using sprain or contusion to an unspecified site or an unknown site, be specific. Use contusion of the elbow due to a ground level fall or sprain of the elbow due to the ground level fall. Again, that location of the injury is important and makes it more specific. We always want to include the laterality and location when appropriate. Continue with the same example. The final diagnosis should read contusion of the left elbow due to ground level fall, initial encounter. Again, noting that it's the left elbow and being consistent throughout the chart is important as we make this final diagnosis. We always want to apply the terms acute and chronic when appropriate. When relevant, also include acute exacerbation of a chronic condition. In the current example we've used of the 2-year-old with the fall, the injury would obviously be acute, an acute contusion or an acute sprain. In another case, 65-year-old female with a history of rheumatoid arthritis and severe pain in both hands for 2 days after doing needlepoint. This would represent an acute exacerbation of her chronic condition. and the final diagnosis should reflect accordingly. Be as specific as possible. In this case, the diagnosis should read, acute exacerbation of chronic rheumatoid arthritis affecting the right and left hands at the PIP joints. When a chronic condition exists, always include complications of that condition if present. As an example of this, a diabetic patient with glucose of 325 and creatinine of 2.4 presents with pneumonia, which you appropriately diagnose as acute community-acquired lobar pneumonia involving the left lower lobe. The additional diagnosis of diabetes mellitus is not enough. Instead, the diagnosis is better documented as chronic diabetes mellitus type 2 with associated acute hyperglycemia and chronic kidney disease. Being specific allows the coders to code this most appropriately. When a diagnosis of abnormal lab value is present due to an underlying condition, always specify what the condition is. An example here would be a patient presents with chronic kidney disease and a creatinine of 4.6. They have a hemoglobin and hematocrit of 6.4 and 19 respectively. They are obviously anemic. In the absence of another source for the anemia, their anemia is attributed to their chronic kidney disease. Do not simply document chronic anemia due to underlying disease process. Instead, be specific. Document chronic anemia due to chronic kidney disease, which is likely due to chronic hypertension and poorly controlled type 2 diabetes mellitus. Don't simply list the abnormal lab value, but also include the cause for its presence. As providers, we want to get credit for the work we're doing. Our documentation is our best representation of that body of work. It is important that our documentation accurately captures each encounter. This is important for a lot of reasons. It's important for the patient and for those who see them in follow-up. It's also imperative that we as providers do our part to combat bad payer behavior by documenting completely and specifically. The details are important. Make sure we are capturing the full story in all of its complexity, including accurate and specific diagnoses. It's not likely that we will ever overcome all the challenges and obstacles that payers are using to reduce or withhold payments for our services. But using the suggestions above and being as specific as possible in our documentation of the final diagnosis is best practice and should mitigate at least some of the bad payer behavior.